Wonderful. Good afternoon. I'll go ahead and get us started. Welcome everyone to Neurology Grand Rounds. My name is Meridale Baggett. I'm one of the associate editors of the case records of the MGH, which are published in the New England Journal of Medicine and one of our very long-standing traditions in medical education here at Mass General. I'm happy to welcome you all here today. We have an absolutely fantastic case to share with you. We think there'll be some really wonderful teaching that will happen today. Dr. Arun Venkatesan is our primary discussant. He agreed to discuss this case in the traditional unknown format, which means that all that he knows about this patient is a case summary that I sent to him about 6 weeks ago so that he would have time to prepare his thoughts. We do this in the unknown format because we think it's a really wonderful teaching exercise to be able to hear from him how he would approach this patient in real time without the benefit of already knowing the diagnosis. So we're very much looking forward to your teaching today. Dr. Venkatesan is joining us from Johns Hopkins, where he is the director of the Johns Hopkins Encephalitis Center. And we're very grateful that you are joining us today and looking forward to your teaching. Dr. Venkatesan will be joined today by Dr. Romero, who will be going over the relevant imaging for this patient. And then we will hear later in the conference from both Dr. Harrold of neurology and Dr. Klontz from pathology about how things turned out for this patient in the long run. But first, it's my great pleasure to invite Dr. Bonkhoff, who's one of our neurology residents. She was one of my preliminary interns last year, and she's going to present the case of this gentleman, this 69-year-old man with ataxia and headache. So I will turn it over to you, Dr. Bonkhoff. Thank you for joining us.
Thank you for the introduction, Dr. Baggett. So, as already mentioned today, we will be discussing the case of the 69-year-old man with ataxia and headache. And with respect to how did he present? So 2 weeks prior to his presentation to the ED, he actually sustained a fall while he was sailing. Up to that point, he had been in his very usual state of health and he was very active. So, for example, he engaged in multiple water sport activities. After the fall, what he noticed was a pain in his mid-back and then also over his right lower ribs, more to the back. He additionally noticed a progressive weakness of both of his hands and some difficulties coordinating them that progressed up to the point that he was not able to feed himself anymore. He additionally had a headache that was similar to prior migraines, and in the end, it was his wife that brought him to the emergency department. A few things to know about his past medical history. So of note, he was diagnosed with a diffuse large B-cell lymphoma 3 years prior to his presentation. The initial treatment consisted of bendamustine and rituximab. Then 1 year after the initial diagnosis and 2 years prior to coming to the ED, he also noticed a right hand weakness. A brain MRI found that he had a lesion in the left centrum semiovale, which a biopsy showed was positive for EBV positive diffuse large B-cell lymphoma. He was started on CAR T-cell therapy that was transitioned to ibrutinib, which was continued up to the point that he developed cryptococcal pneumonia. After these treatment courses, he was thought to be in remission with respect to his lymphoma. He still underwent surveillance imaging. The last set of images was obtained 4 months prior to his current presentation. With respect to his neurological exam, it was documented that he had residual right arm weakness. So his strength was documented as 4 out of 5, and he had reflexes increased to 3+ for the right brachioradialis, biceps, and triceps. Other items that are important to know. So he had hypogammaglobulinemia after receiving rituximab and then persistent lymphopenia after the CAR T-cell therapy. He was noted to have hypertension, dyslipidemia, non-ischemic dilated cardiomyopathy, urinary retention, superior mesenteric vein thrombosis, and ADHD, as well as a mood disorder. The medications he was taking for these diagnoses. So he was taking acyclovir and Bactrim prophylaxis, and then apixaban, atorvastatin, dextroamphetamine, amphetamine, empagliflozin, fluconazole, metoprolol, sacubitril, valsartan, tamsulosin, and venlafaxine. In addition, he received periodic IVIG infusions that was for infection prevention. Some information about his social history. So He was retired from work in real estate. At the time of presentation, he was living in a house with his wife and dog near a lake that was in suburban Boston. As mentioned initially, he engaged in water sport activities, particularly swimming and paddle boarding. He was also known to work in the yard. While he didn't remember any mosquito bites, he did remember some ticks. There was no intake of dairy meats or unpasteurized dairy products. With respect to his smoking history and alcohol, we knew that he was a lifelong non-smoker and did not have any alcohol or drugs. So his physical examination at presentation, his vital parameters were all within normal ranges. So he was afebrile, oxygenating well on room air. He was attentive to the conversation and fully oriented and able to follow two-step commands. Some pertinent items for his neurological exam. So his speech was slow and mildly hypophonic. He had nystagmus at lateral end gaze that was to both the left and the right. He had some increased tone for his right arm and leg, and weakness mostly for finger abduction, and that was on both sides. Just like he was found to be ataxic also on both sides in the nose finger testing. Some fasciculations were noted for the muscles of his legs. The exam for the right arm was consistent with the documentation prior to his hospital visit. So he had weakness and hyperreflexia of the right arm, otherwise strength and reflexes were within the normal range, as was his sensation. With respect to the labs that were obtained upon his initial visit, so his electrolytes, glucose, liver, and kidney function tests were all resulting with within the normal ranges. Vitamin B12, TSH, zinc, and copper, likewise. He had negative infectious studies for HIV-1 and 2, Lyme, and syphilis. And with respect to his complete blood count, he was found to be lymphopenic, which is in line with what was known about the patient, but otherwise the levels were normal. CT head imaging once again showed what was known based on prior imaging. So he had a calcified lesion in the left centrum semi-ovale. Systemic imaging, so CTA, chest, abdomen, pelvis, and CT cervical spine primarily showed that he had fractures of the 11th and 12th rib on the right and some degenerative changes of cervical vertebrae. And to now talk about his hospital course. So initially he was admitted and apixaban was stopped. On day 2, he underwent brain MRI that once again showed the calcified lesion in the left frontal lobe. On day 3, he then underwent EMG and nerve conduction studies that were suggestive of an early chronic polyradiculopathy. On day 4, he had a clinical change. So he had worsening hypophonia, worsening ataxia, and then a new truncal ataxia in combination with lethargy. On day 5, this clinical worsening continued, and he now had difficulties swallowing, as well as a new palsy of both of his 6 cranial nerves. He was started on empiric antibiotic and antiviral therapy, consisting of ceftriaxone, vancomycin, acyclovir, and ampicillin. On day 6, he then underwent a lumbar puncture. His opening pressure was 15. It was pleidocytic, mostly lymphocytic, so 21 cells. The gram stain did not show any bacteria, only mononuclear cells. Of note, there was no evidence of a monoclonal B cell population. Then, on day 9, he underwent repeat brain MRI, now showing flare hyperintense lesions in both of his cerebellar hemisphere cortexes and cerebellar folia, as well as the brainstem. There was no enhancement.
Hi there. Thank you so much for the opportunity to share my thoughts about this really fascinating case. And Dr. Bonkhoff, very nice presentation. So I'm going to go through my thoughts here. And what we'll do is first just do kind of a broad recap, and then we'll get going. Okay. So in terms of the recap, okay, got the slide controls. All right. So 3 years prior to admission, the patient was diagnosed with a diffuse large B-cell lymphoma that was treated. 2 years prior, developed a CNS manifestation, likely of that same diffuse large B-cell lymphoma. That was treated with CAR T therapy that resulted in persistent lymphopenia. About 18 months prior to admission, the patient developed cryptococcal pneumonia that was treated and that then resulted in the cessation of the treatment for the CNS lymphoma. Now, the patient was followed every 6 months with serial neuroimaging, and that CNS lesion was noted to be stable over that period of time. That brings us to the current admission, where again, 2 weeks prior, the patient underwent a sailing accident and then was noted to have a headache and progressive incoordination over the 2 weeks leading to admission. Okay, so the approach that I thought we would take would really be to focus initially on the localization, because I think that that's really important for this case. And then we'll bring in other elements of the history, the exam, and the laboratory studies in order to further refine our differential diagnosis. So in terms of localization, we know that there's chronic right arm and leg weakness as a result of the CNS lymphoma. And so we're going to put that aside at this point. That's chronic, that's not new. What is new is the incoordination. And so what was noted on exam was bilateral ataxia on finger, nose, finger testing. And if we think about where that localizes to, it really localizes to the cerebellum. I'm showing you an inferior view here of the cerebellum. And ataxia in the arms, in the legs, localizes to more lateral structures of the cerebellum. That is either the paravermis or the lateral hemispheres. Okay? And that's bilateral in this case. In addition, the patient had nystagmus at end gaze bilaterally. And I'm going to assume that this is a problem of gaze holding. The cerebellum is really important for our ability to maintain our gaze eccentrically. So we move our eyes off of midline, and the ability to keep our eyes off of midline is controlled in part by the cerebellum. That function appears to have been lost here. That function is really encoded in the inferior portions that are more medial here in the cerebellum, in particular the tonsils. And then finally, what we find is that over the course of the hospitalization, there's evolution of the patient's symptoms and a truncal ataxia develops as well. And that localizes right here to the midline of the cerebellum, the vermis. Okay? So if you think about all of these in combination, this represents a very diffuse cerebellar process that's involving the midline, lateral portions of the cerebellum, and the inferior portions as well. Now, let's just start with that then in terms of the localization. There's, of course, more to it, and we'll unpack some of it in a moment. But let's put that together with the tempo of disease here. We know the cerebellum's involved. There are so many things that can cause cerebellar dysfunction, but what can do this over a few weeks in progressive fashion? So I've listed some of the categories of disease that come to mind. Certainly malignancy, infection, trauma, toxic or metabolic processes, and immune-mediated processes are the ones that I was considering most strongly at this point. There's additional localization to think about, and that's going to help us to refine our differential here. The patient had a headache, had bilateral 6-nerve palsies, probably had some additional brainstem dysfunction as well, and a polyradiculitis. But if we just take these in combination, okay, certainly a diffuse process, a multifocal process of the nervous system could cause this. But in addition, one can think about the subarachnoid space as a very specific localization, dysfunction of which could lead to headache, cranial nerve palsies, and a polyradiculitis. Let me explain. So the meninges are exquisitely pain-sensitive structures. And so if you have some dysfunction in the subarachnoid space, that can be captured by the meninges which surround that space and reflected as a headache. Moreover, cranial nerves and spinal nerve roots have to pass through the subarachnoid space before they get out to their targets. Here's just a schematic. This is the brainstem schematized. Here's a cranial nerve nucleus in the brainstem. It's going to eventually project extracranially, but in order to get there, as it exits the brainstem, passes through the subarachnoid space here. And I'll convince you of that here on this MRI right here, where I'm going to orient you. Here's the midbrain. Here's the pons. Can you see my arrows? I assume you can. You can't. Okay. Unfortunately, you can't. The dark areas on the right are the brainstem. Okay. And the top area is the midbrain. The kind of bulbous-looking area is the pons, and below that is the medulla. And the black arrow is pointing to a dark structure that's exiting the pons. That's the sixth nerve. And you can see that it exits through a very bright, hyper-intense area. That's subarachnoid space. So I think you can see that if you have dysfunction in the subarachnoid space, that can be reflected as cranial nerve pulses. Okay. So let's move on to the next slide. So let's then refine our localization a little bit. We know that the cerebellum and probably the brainstem, as well as the subarachnoid space, is involved. Where does that leave us in terms of categories of disease? Well, in terms of these categories, I think the ones that are left remaining to consider are malignancy, infection, trauma, and immune-mediated causes. I think effectively, based on this localization, we've ruled out toxic and metabolic conditions. Okay, so Dr. Romero, you're on.
Thank you so much. Yeah, good afternoon, everyone. Next slide, please. So our first set of images for this patient is an admission non-contrast CT of the head. We have axial views, and your left hand, you can see this hyperdense lesion within the frontal lobe. This lesion is likely a calcification. We know the patient had a foci of abnormality on the prior, and this likely is post-treatment effect. I'm highlighting the visualization of the posterior fossa on the right-hand images. As you can see, the cerebellum shows normal size and normal density as well. Next slide, please. This is the MRI of the brain performed on day 2 of admission. And as we can see on your left hand is susceptibility weighted images, which is a sequence very sensitive to either blood or mineralization. In this particular case, we can see that there's low signal intensity where you see the red arrow with a peripheral area, likely representing mineralization and calcification from prior treatment effect. We also, retrospectively looking into the cerebellum, we can see some signal abnormality particularly within the left cerebellar hemisphere and partially within the vermis. Now, this is an area of particular difficulty, given that we find that there's significant pulsation artifact from the transverse sinuses that could simulate this signal as well. Diffusion-weighted images show no evidence of restricted diffusion, and T1 post-contrast, as you can see, demonstrate no enhancement within the cerebellar hemispheres. Just of note, you can see within the superior calvarium, there is a burr hole, and that is where the biopsy tract was performed for this primary disease. Next slide, please. Here we see 2 sets of row. The first upper row is all FLAIR images demonstrating a progression of signal abnormality within the superior cerebellar folia and also on the gyruses. You can see that there is high signal intensity, not only on the left side, but also on the right superior cerebellar hemisphere. And on the last image on your right, you can see that there's some signal abnormality also within the pons and some within the brachium pontis. The cerebellum here is very compromised, is bilateral. Administration of contrast on your lower row, you can see that there's no evidence of abnormal enhancement within the cerebellar hemisphere or within the pons, and there's no evidence of restricted diffusion. So we are here, at least imaging-wise, we are confronted with some inflammation of not only the cerebellum, but also parts of the brainstem, which we considered a combination of rhomboencephalitis and cerebellitis. Next slide, please. Within the differential diagnosis from the radiological standpoint, we find that this patient had a cerebellitis and a rhomboencephalitis of rapid progression. You can see that this evolved during 7 days. Given his precedent of immunosuppression, obviously infectious comes up into the list. Paraneoplastic, more related to small cell lung cancer, however, could also be present in other types of cancer. Autoimmune, and we considered tumor as less likely given the fact that there was no evidence of enhancement or mass-like lesion within the cerebellum, as well as a very rapid progression for any neoplasia to be present. Thank you, Dr. Venkatesan.
Great. Thanks, Dr. Romero. So to move forward, okay, we talked about 4 categories of diseases that we're thinking of: malignancy, infection, immune-mediated, and trauma. There are a couple of traumatic processes that could kind of link together the cerebellum and brainstem with the subarachnoid space. One is hemorrhage, and that was really effectively ruled out by the initial CT. The second is an interesting one to think about: a traumatic CSF leak resulting in CSF hypovolemia or hypotension. You've probably all seen this in the case of a lumbar puncture, where post-LP, some patients will develop symptomatology, usually a positional headache, but occasionally it can be severe and you get traction on the meninges as a result of sagging of the brain. You can get dysfunction of cranial nerves, spinal nerves, and crowding of the cerebellum. So when we're thinking about a process affecting the posterior fossa and the subarachnoid space, certainly this could be a consideration. But again, the symptomatology wasn't positional, and it isn't always, but classically it is. And the MRI really wasn't compatible with a CSF leak. So that leaves us with categories that are echoed by Dr. Romero, malignancy, infection, and immune-mediated categories. And so we'll go through these fairly systematically. I'll say that although my focus is on infection and immune-mediated processes, I'm going to be very broad in terms of the thinking here, because I was recently involved in a CPC at Hopkins where these categories were the main considerations, and the patient turned out to have a malignancy. Thankfully, I was on the right track there, but I still haven't forgiven my colleague for putting me in that position. There's additional support for these categories provided by the CSF findings, of course, which demonstrate a lymphocytic pleocytosis. All right. So first of all, immune-mediated causes, I found these to be quite unlikely given the immunocompromised state of the patient. You'll note that not only was he persistently lymphopenic, but he also had a hypogammaglobulinemia, which was treated, of course, with periodic IVIG, but nevertheless quite immunocompromised from both a humoral and a cell-mediated standpoint. But when we think about potential immune-mediated causes that can affect the cerebellum and that can unfold over weeks, we're really thinking about a couple of things. Autoimmune cerebellar ataxias, which may or not be driven by a tumor as a manifestation of a paraneoplastic syndrome, and then demyelinating syndromes. And so let me just talk briefly about each of these. So in terms of autoimmune cerebellar ataxias, if you take all adults who develop a sporadic cerebellar ataxia, autoimmune causes account for about 6% of those cases. And of those, the most common autoantibody that's identified is to GAD65, glutamic acid decarboxylase 65. Neurologic syndromes associated with this antibody include a cerebellar ataxia, stiff person syndrome, and epilepsy. And these can occur alone or in combination. It's worth just thinking about the potential pathophysiology of this disorder, although we're not sure if this really underlies the process or not. But this enzyme converts glutamate to GABA. And you'll recall that glutamate is one of the chief excitatory neurotransmitters in our nervous system, GABA, one of the chief inhibitory neurotransmitters. So if there's a potential failure of this enzyme, one may build up glutamate, one may shift the balance towards excitation in the nervous system, and you might get things like stiff person syndrome and epilepsy as a result of aberrant excitation. And moreover, you may develop excitotoxicity in the nervous system, and you can get degenerative conditions such as a cerebellar ataxia. So again, that's the most common autoantibody-associated cerebellar ataxia. Your head will spin if you try to come to terms with the dozens of additional autoantibody-associated cerebellar ataxias that have been identified recently. I've listed a few of them here. There's a nice review, the reference of which I've listed in the slide for those who are interested. But in general, these can progress over weeks. The acute imaging is usually normal. Eventually, these patients will develop cerebellar atrophy. And so in a patient who weren't so immunocompromised, I think that these would be considerations. Now, of course, there's concern for malignancy in this patient, and we'll tackle that squarely in a moment. But malignancy can drive paraneoplastic conditions as well that have an autoimmune basis. And these are the paraneoplastic cerebellar ataxias. The classic syndrome that probably most of you have heard of is an anti-Yo associated syndrome in women. It's associated with ovarian cancer predominantly, and sometimes with breast cancer as well. And it results in progressive, quite rapid cerebellar degeneration. Now in men, patients with Hodgkin's lymphoma can develop what's called an anti-TR antibody. This is another Purkinje cell antigen. I should mention that the Yo antigen is also present on Purkinje cells. These are some of the chief neurons that are present in the cerebellum. And so these patients, the men with Hodgkin's lymphoma, can develop this paraneoplastic cerebellar ataxia, as can men with testicular seminomas. There's a recent autoantibody called Kelch-11 that was identified in a beautiful study that was published about 5 years ago in the New England Journal. This was a patient who had this progressive cerebellar syndrome and in whom phage display was used to, in an unbiased fashion, essentially identify the autoantibody. And that was found to be this Kelch-11 autoantibody. We're now seeing more and more cases of this as we now look for. And again, these progress over weeks to months. In our patient, the real concern is CNS lymphoma. And these diffuse large B-cell lymphomas are seldom associated with paraneoplastic syndromes. And so because of that, and because the patient's immunocompromised, again, I think we're not going to consider these further. Certainly, we have to think about demyelinating and inflammatory syndromes of the central nervous system that can affect the cerebellum and brainstem. ADEM is the classic one, and the classic MRI is this. You see multiple enhancing lesions. They're distributed throughout the subcortical white matter. Sometimes they can be focused in the posterior fossa, and you can get a cerebellar syndrome. Other demyelinating syndromes to consider, there's myelin oligodendrocyte glycoprotein antibody-associated disease. This most commonly is associated with optic neuritis or transverse myelitis, but sometimes we see brainstem or posterior fossa presentations, as I've shown you here. As you'll note, these are typically accompanied by enhancement on MRI and edema and mass effect associated with the acute inflammation. Similarly, systemic processes like sarcoid, Behçet's, and histiocytic disorders, which can sometimes affect the cerebellum, you're going to see some imaging correlates that we didn't see in the current case. Okay, so next, malignancy. This is, of course, the elephant in the room, right? This is a patient with a systemic B-cell lymphoma and then a CNS lymphoma and comes in with progressive neurological symptoms and signs. Malignancy has to be very high up on the differential, right? This patient had an EBV positive diffuse large B-cell lymphoma. And I'm mentioning that because the patient also had sustained lymphopenia and therefore likely deficient cell-mediated immunity. This would put them at increased risk for a recurrence of their lymphoma. Why is that? Because when we are infected by EBV, we develop EBV-specific, memory T cells and other cells that are going to suppress the life cycle of the virus in our lymphocytes. Recall that the virus, once it infects us, it sits in our lymphocytes in a latent form and can sometimes be reactivated to its lytic form. Well, our T cells are really important for control of that process and for maintaining EBV in its kind of dormant state, preventing it from reaching its oncogenic potential and triggering lymphocytic proliferative disorders and lymphomas. So this patient doesn't have likely that kind of cell-mediated immunity to control the EBV. What I think wasn't mentioned in the initial presentation, but information that I had about the CSF cytology, is that it showed enlarged lymphoid cells with prominent nuclei and abundant cytoplasm. And this again raises the possibility of a malignancy, potentially one driven by EBV. However, I'll show you that the imaging really isn't consistent with a CNS lymphoma. Most CNS lymphomas look like this. And so on the right, you'll see a post-gadolinium scan, lots of enhancement, homogeneous enhancement. On the left, you'll see a lot of mass effect. You can see the ventricle's been squished. There's midline shift as well. Now, patients with EBV positive diffuse large cell B-cell lymphoma can have atypical imaging features. It can look a little more like this. And so you might just see on the right lower panel some peripheral enhancement. There may be some more subtle edema, but it's there nevertheless. You can also get a primary leptomeningeal lymphoma that's been described, but again, you'd expect to see enhancement in all of these cases. We didn't see that. The imaging really isn't consistent with this process. And moreover, the flow cytometry did not confirm a clonal B-cell population. So all of these argue against CNS lymphoma. Now, what about metastatic disease? We could consider that. The patient's undergone multiple immune treatments. Perhaps they're now susceptible to kind of secondary malignancies. The posterior fossa is the primary site of about 15% of all CNS metastases. And very rarely, you can actually have metastases to the leptomeningeal space. And this can involve the posterior fossa, cranial nerves, and nerve roots as well. This is an example of a breast cancer that metastasized to the leptomeninges of the posterior fossa and presented very similarly with a progressive ataxia and brainstem symptoms. But again, in this case, the other thing I'll note is that the sensitivity of CSF cytology is very suboptimal for detecting these metastatic disorders to the central nervous system. But again, here, lack of a known systemic tumor and some of the imaging characteristics as well really argue against metastatic disease as the culprit. We have to think about primary glial tumors. Most primary glial tumors are space-occupying lesions, right? Think about a GBM, a glioblastoma, right? The one exception is gliomatosis cerebri, and I've shown you an example of that where you get this really kind of infiltrative process that most commonly will affect the subcortical white matter. Very rarely you can get involvement of the cerebellum. Here's a case report that I found. But again, it's quite rare to affect the posterior fossa. I wouldn't expect such rapid progression either of disease, okay? So that brings us to infection, all right? The host is immunocompromised. We have rapid progression. There's a CSF pleocytosis. We've got to be thinking about infection. We need to be thinking about really all classes of pathogens here, but I'll tell you that really the diffuse parenchymal involvement that we saw both in terms of localization and in terms of the radiology without much mass effect, and the progression despite multiple antimicrobials, really, I think, will focus the discussion on viruses. So we'll end there. But before we get there, I want to touch on a few other potential pathogens that we need to consider, at least here. The first is prion disease. And the reason we need to consider that really is the patient age and some of the clinical manifestations. So age is certainly a risk factor. And you can see here that the incidence, although rare, right, peaks in those in their 60s and in their 70s. Think about Creutzfeldt-Jakob disease when we're thinking about prion disease, okay? Now, the pathogenesis, you may recall, has to do with misfolding of endogenous proteins. We have prion proteins in our nervous system and really throughout our body, and typically this adopts an alpha helical secondary conformation, okay? But in prion diseases, that alpha helix gets converted to a beta pleated sheet, and this conformation of the protein can then result in a domino effect and convert more and more of the cellular conformation to the beta pleated sheet conformation, okay? And that can result in progressive neurologic dysfunction. One of the core manifestations really is cerebellar disturbance, as you can see here. But there are a number of things arguing against prion disease here. One, the progression is very rapid, okay? Usually, although we call this a rapidly progressive dementia, the progression is over months typically, okay? Second, you can see that there's this bottom left panel, there's typically widespread neurologic dysfunction, dementia plus other manifestations. We didn't really see that here. Third, there was a CSF pleocytosis. I told you that the pathogenesis of prion disease involves endogenous proteins. These don't typically elicit a strong inflammatory response. So you wouldn't really expect much of a pleocytosis in a prion disease, okay? And then fourth, the imaging really isn't consistent. Classic imaging in prion disorders is restricted diffusion on MRI in cortical and deep gray areas, and we did not see that in this case, okay? So next, the patient had exposure to fresh water, right? We think fresh water, certainly water, and I'll assume that some of that was fresh water. And in that case, we have to be thinking about protozoa, and in particular, we need to think about Naegleria fowleri, a free-living amoeba that resides in freshwater bodies, okay, that enters via nasal passages, okay, and causes a necrotizing encephalitis, all right? Now, typically, it is going to enter through the nasal passages and get into, via the cribriform plate to frontal areas of the brain. It's very rarely going to get to the cerebellum. So again, our localization is helpful here. A primary cerebellar process really isn't consistent with Naegleria fowleri, nor is the fact that on MRI, we didn't see evidence of necrosis, right? And then finally, I'm presuming that all of the water exposure here was in New England, and that those bodies of water are fairly cold and don't typically support Naegleria fowleri, although who knows with global warming how this might change. Typically, Naegleria fowleri is found in warmer bodies of water, for example, in the southern US. Okay, let's turn to bacteria. Certainly, we're not considering pyogenic bacteria here. There are a number of bacteria that in the setting of immunocompromise, as is the case here, that we would need to consider. For example, mycobacteria, and for that matter, fungal infections as well. These are going to present typically with a basilar meningitis, okay, meningitis at the base of the brain, and a space-occupying lesions. We didn't see that here. One bacteria that we need to just briefly spend a moment on is Listeria monocytogenes. You know that this is a bacterium that is particularly common in immunocompromised individuals. It's a facultative intracellular bacterium. So because it sits within cells, it doesn't elicit as robust of an inflammatory response as pyogenic bacteria. You can get a more subtle clinical presentation and more subtle CSF findings, okay? And so certainly could be a consideration here. It commonly leads to a meningitis, and it can lead to a rhombencephalitis affecting the brainstem. But usually you're going to see multiple abscesses, as you see here on the sagittal T1 postgadolinium. You're seeing a bunch of abscesses studding the posterior part of the brainstem, the pons and the medulla in particular here. And we didn't see that in this case, okay? So let us, before we move on to viruses, just one aside. The patient had tick exposure. So we have to be thinking about tick-borne bacteria as well, Lyme disease. But this patient did not have positive Lyme antibodies and progressed despite adequate treatment. Okay, there are other tick-borne bacteria that could be considered, but very unlikely given the clinical presentation here. Okay, so that brings us to viruses. We think that's most likely, okay? The patient had tick bites, clearly has a lot of outdoor exposures. So we do have to think about occult mosquito bites as well. West Nile, Eastern equine encephalitis virus are both present in New England and are considerations. Now, these arthropod-borne viruses usually involve the deep gray matter rather than cerebellum, although I'll tell you there are some cases of West Nile-associated cerebellitis. So we do have to think about that as a possibility. Another virus to think about in the setting of immunocompromised state is JC virus, okay? You know that this is the virus that is linked to PML, progressive multifocal leukoencephalopathy. This infects astrocytes and oligodendrocytes, usually in the subcortical white matter of the brain, but sometimes can start in the posterior fossa. And it can affect the white matter of the cerebellum. It spares the deep gray matter here, and as a result, gives you a sign called the shrimp sign, as you can see here, quite self-explanatory. There's a bilateral shrimp sign here in this patient who developed a posterior fossa predominant JC virus PML, okay? The other syndrome that JC virus can cause is a granule cell neuronopathy. You can actually get mutations in the virus that shift the tropism from glial cells to neurons, and you get progressive cerebellar degeneration. But the time course of both of these, PML and granulocell neuronopathy, is usually much slower than what was seen here. So I think that's very unlikely. The other set of viruses that we have to think about in an immunocompromised individual are herpes viruses. Epstein-Barr virus and VZV, again, once they infect us, they reside lifelong and can reemerge later in life, particularly in the setting of immunosuppression. And both of these have been linked to a cerebellitis, okay? And I should note that the pathogenesis could be direct or a para or post-infectious inflammatory process. I also want to note that reactivation of varicella zoster can certainly occur without the rash and despite acyclovir prophylaxis. This patient was prophylaxed, but still is at risk for VZV reactivation. Okay, so that's going to lead us now to, I think, the consideration that I am thinking most strongly about. This patient developed, after a tick bite, progressive neurologic deterioration, okay? Had involvement of the cerebellum and the brainstem, okay? Had cranial neuropathies, had a relatively modest pleocytosis, okay? And progressed despite multiple antimicrobials, including acyclovir. So I think that this patient had Powassan encephalitis, okay? And again, tick bite followed by progressive neurologic symptoms. In a recent case series, rhombencephalitis, so the clinical syndrome of a brainstem encephalitis, was found in 6 out of 16 patients. Cerebellum involvement on MRI was found in about a third of patients. There can be a delay in the radiographic abnormality. So our patient, the initial MRI was fairly unremarkable, and it was only many days later where the MRI really confirmed the clinical localization, right? The degree of pleocytosis can be fairly modest, and in fact, in some cases can be normal initially, okay? And so again, I think the constellation of the exposures, this particular patient, and the clinical and radiographic abnormalities really point to Powassan encephalitis. So you may be asking then, well, what about those atypical cells found on CSF cytopathology? I think they just reflect lymphocytic activation. This can be seen in a variety of infectious and inflammatory disorders. And then you may ask, well, this is an infection. Why aren't we seeing enhancement on brain MRI? I think that's because of the immunocompromised state of this patient. And a final note, this patient had a polyradiculitis on EMG and nerve conduction studies. What turns out a very closely related virus, tick-borne encephalitis virus, has been associated with a polyradiculitis as well as CNS manifestations. So what would I do here? I would test for Powassan virus. Now, there are a couple of different ways to test for this. Classically, for arthropod-borne viruses, we would test for serology. We would test for the CSF IgM against Powassan virus. But this patient is immunocompromised and may not have developed antibodies against Powassan. And so I think a more sensitive test here would actually be a CSF PCR for Powassan virus. Thank you.
Wow, absolutely fantastic, elegant, very clear discussion of your thought process and how you would have thought through this patient in real time. Thank you so much for walking us through that. Okay, I'm going to move us on. Now you get to figure out whether you were right or not. Dr. Klontz is going to talk with us about the diagnostic test. Erik, I'll invite you to unmute and I'll advance your slides for you.
All right, and so a diagnostic test was performed. Next slide, please. So CSF was sent to a reference laboratory where PCR for Powassan virus was performed. And before I share that result with you, I'll pause for the virtual applause and give a little bit of background on Powassan virus to contextualize it. Next slide, please. So Powassan virus was discovered in 1958 in Powassan, Ontario. If you've ever taken a road trip there in the summer, as I have, you'll see a landscape that looks like this. If you look below the slide, below the sign, you see a lot of tall grass, which is the perfect environment for the vector ticks. Next slide. So initially, in the 1950s, it was found to circulate mostly in various species of Ixodes ticks and the small ground mammals that they feed off of, where human infection is the result of an incidental bite, and humans are dead-end hosts. Next slide. It wasn't until the late 2000s that another strain of Powassan virus was discovered, And this was a strain that circulated in Ixodes scapularis ticks, also called black-legged ticks or deer ticks. And this was a significant finding because this is a tick that is very aggressively bites humans. It's the same tick that spreads Lyme disease, Babesia, and Anaplasma, so it's highly capable of transmitting disease to humans. These viruses were found to be genetically distinct, and so you can see on this phylogenetic tree an early branch point, and they're enzoonotically distinct, circulating in different ticks and different mammals, but they are serologically indistinguishable and clinically indistinguishable, so they're both just considered Powassan virus. Next slide. So this is a chart of reported cases of Powassan virus since discovery in the 1950s. And you can see for many years, until the late 2000s, it was very rare, only about a case per year. However, since the discovery of Powassan virus lineage 2 or deer tick virus, cases have been on the rise. Next slide. So in the top right, you'll see chart of Lyme disease cases in 1996 and in 2018. And you can see this geographic spread in New England and in the upper Midwest. So it should be no surprise if you look at the geographic distribution of Powassan virus on the next slide. It's overlaps substantially. So again, in New England and the upper Midwest. And this is probably due to the shared vector of the Ixodes scapularis tick. Next slide. So there's a figure from a recent publication we wrote on laboratory testing for Powassan virus, and it applies nicely to this patient. So I'm going to walk us through this and show how to test for this virus. So next slide. So infection begins with a bite of infected tick, and the infection can be transmitted in as little as 15 minutes. What follows is an incubation period where the patient is asymptomatic for days to weeks. And many patients, but not all, will then develop a variable prodrome. Next slide. This commonly includes a headache, as this patient had, but more commonly there are other non-specific viral symptoms, which this patient did not have. Some patients will return back to their baseline for a brief period of time, while others will transition directly into the meningoencephalitis phase of disease. Next slide. These patients often have headache, confusion, focal deficits, as this patient did. Many of them will also have seizures, and about 15% of them will die during this phase of disease. Some will recover over weeks to months to years, but many others will be left with persistent sequelae. So to diagnose Powassan virus, it can be actually very challenging because there's no single test that works for all patients at all phases of disease. So you have to also specifically think of it since it's not on any syndromic panels, and at least at our institution, not on any order sets. So you have to think about what phase of disease is the patient and what is their immune status when picking the right test. So next slide. So first, regarding the phase of disease, this patient was somewhere around here on the dotted line. Their meningoencephalitis was progressing. It was severe by day 6 when the lumbar puncture was performed. At this time period, basically all patients are going to have basic tests such as CSF cell counts, chemistries, and a brain MRI. And on the next slide, you can see that this patient had the classic findings: a lymphocytic pleocytosis, elevated protein with normal glucose, and abnormalities most common in the cerebellum and deep gray structures. And as Dr. Venkatesan said, the brain MRI findings can often lag the other clinical findings in the CSF abnormalities. I saw a chat says the slides are not forwarded, so I think they're just showing the highlights in yellow, so I hope you can see that. Okay, so when you have this constellation of symptoms, you have to think about the right diagnostic test. So as Dr. Venkatesan was saying, in an immunocompetent patient, the mainstay diagnosis is made via IgM serologies. And this is because nucleic acid is very, very transient in the immunocompetent host. By the time these patients seek care, oftentimes it's not detectable. But the immune response is readily detectable. So in all but the earliest stages of disease and the latest stages of recovery, an IgM will be positive in the immunocompetent host. However, this patient was immunocompromised, and particularly in that host, they had, if they received rituximab or other B-cell depleting therapy, you can't rely on a serology. And if you ever have doubts about that, you can measure the immunoglobulins, which was done in this patient. If you advance the slide, you'll see that the immunoglobulins were low across the range. So an IgM serology is negative, falsely negative, in about 95% of arbovirus infections in patients on rituximab. So PCR, however, is highly sensitive. These patients tend to have more severe infections and delayed viral clearance. So nucleic acid can be detected well into the meningoencephalitic phase in this population. Next slide. So blood, urine, and CSF are all substrates that can be tested. We have the most experience sending CSF, which is reliable in our experience, and so we tend to recommend that if it's available. All right, next slide. So CSF was sent to the reference laboratory where PCR for lineage 1 and lineage 2 was performed. You can see that lineage 1 was negative, but lineage 2 deer tick virus was positive. Next slide. So this gives us a final diagnosis of Powassan encephalitis.
Thank you so much, Dr. Klontz. So now I invite Dr. Harrold to talk with us about management.
Yeah, thank you for the opportunity to talk about this patient's course as he was managed. So when he first was hospitalized, as we'd heard, he was already below his baseline clinical status, but that just as a qualitatively continued to decline over the first few days throughout his hospitalization. And so you can see as he continued to decline, the inpatient team started him on empiric antimicrobial therapies, including acyclovir to cover HSV and VZV, ampicillin to cover listeria, as we heard about, and then ceftriaxone and vancomycin, both as empiric meningitis coverage, but also with the thought that the ceftriaxone would cover Lyme disease or borrelial infection. The team waited until day 5 after the LP to start dexamethasone, and that was done in order to empirically treat the possibility of recurrence of his lymphoma, since he was getting worse, and they wanted to kind of make sure that they weren't missing anything. And the reason to wait to give the dexamethasone was to not decrease the yield of the CSF cytology flow cytometry. You'll see around the time that he started on dexamethasone and a few days into the antimicrobials, there was some sense of clinical improvement. I think it's always hard to know if that's correlation or causation. The natural history of this disease, as we've heard, is that it does get better. But regardless, he was continued on the dexamethasone, which was started to taper, and then the antimicrobials were slowly peeled off. So the acyclovir was stopped once the HSV and VZV PCRs returned negative, and the ampicillin and ceftriaxone were stopped once his Powassan PCR returned positive around hospital day 13. You'll see he also did receive 2 grams per kilogram of IVIG a little bit later in the hospital, of course. And this was done, I believe, for 2 reasons. One is as empirical treatment of autoimmune encephalitis, in case that was the etiology. And then also because people often use IVIG empirically for arboviral infections, although that's really not based on any strong data, really on any data, but we think that there's a possibility that it could help, and there's very little downside, especially in these patients who are so critically ill. So you can go to the next slide. So just to summarize, he received empiric antimicrobials to cover herpes viruses, listeria, and Borrelia specifically. He was given dexamethasone to treat the possibility of recurrent lymphoma. And then IVIG is often given for arboviral infections, including West Nile, Tripoli, and Powassan, although there's an absence of data to support this use. And then in terms of general supportive care for arboviral infections, not all this applies to this patient, but certainly they can become obtunded to the point that they need intubation and ventilation for respiratory support. So obviously that's a critical piece of management for patients with that degree of obtundation. Powassan virus especially can cause a cereballitis with mass effects obstructing the 4th ventricle, causing an acute obstructive hydrocephalus. And so those patients obviously need external ventricular drains, as well as consideration of suboccipital craniectomies to relieve that obstruction. And then some of these patients do have seizures, and of course we manage those with anti-seizure medications. None of the first 3 bullet points apply to this patient, but certainly do apply to these patients commonly. And then really the backbone of management for these patients is aggressive rehab therapies with physical therapy, occupational therapy, and speech language pathology to help maximize their recovery over time. Unfortunately, we don't have any targeted treatments at this stage for Powassan virus or the other arboviral infections. And the one thing I omitted from this slide, let's go back one, sorry, is actually that I found this also very helpful to partner with our PM&R colleagues. They can be very helpful in helping patients recover, especially from physical deficits associated with these infections. So then in terms of follow-up, I saw this patient at a 1-month post-discharge office visits with his wife, and they had reported that while at rehab, they had noticed slow but continued improvements. They felt like cognitively he was almost back to his baseline. His exam, on exam, he did still have diplopia, especially on right gaze, and there was direction changing nystagmus in all directions of gaze. He still had a moderate cerebellar dysarthria, so he was intelligible but difficult to understand. His left arm was full strength. His right arm, which was the weaker arm to begin with, was buried between anti-gravity and able to provide some resistance depending on the muscle group. His right leg was barely anti-gravity throughout. And in his left leg, he could provide some resistance to confrontational testing. There was still a severe ataxia in the left arm. The right arm was difficult to assess just because it was so weak, and he was still wheelchair dependent at that time. So our plan at that point was to continue the aggressive PT, OT, and SLP that he had been receiving, with the hope that over the coming months to years, he would have a slow but continued improvement. Unfortunately, I heard from his wife a few months after that he had multiple unrelated intercurrent illnesses with stepwise functional decline after each one. And at that point, they were letting me know that rather than pursue additional aggressive medical care, that they had elected to change his goals of care to focus more on his comfort. And that was the last I'd heard from them.
Thank you very much, Dr. Harrold, for letting us know the outcome for the patient. I think important for us to keep in mind, these are really educational conferences. The goal is to try to get to these diagnoses sooner, but we still are dealing with a lot of pathophysiology for which we don't have great treatments. So it's kind of a stark reminder that we still have a lot of work to do to be able to help care for these patients in a way that can have more of an impact in their ultimate outcome. But thank you very much to all of our speakers. Dr. Venkatesan, could not have asked for a more clear, elegant, thoughtful description of how you would walk through this patient in real time. I think everyone probably learned a ton from that. Thank you to all of our discussants, to Anna for presenting the case, getting away from clinical duties to come and tell us about this patient you cared for on the neurology wards, and to Dr. Klontz, Dr. Romero, and Dr. Harrold. We do have several minutes for questions. I think there was something in the chat about the slides not advancing, but we're good on that. If anyone has any other questions that they would like to put into the chat for any of our discussants. Do any of you have questions for each other? We don't have any questions coming in the chat.
Just maybe a couple of comments. So, it really is true that for these arthropod-borne encephalitides, we don't have much in the way of specific therapies. There was a lot of interest in IVIG, particularly in the setting of West Nile, because many people have been exposed to West Nile virus, and so it's possible that if you can pool antibodies from people who've been exposed, that might be a nice therapeutic intervention. I think the problem is we're not giving it early enough. And so there's been one trial and it failed miserably. And in fact, patients who got the IVIG actually did a little bit worse. And I think it's really a matter of timing is the problem there. And then the second comment about cerebellar dysfunction is that, once cerebellar Purkinje cells in particular are damaged, there's just very little scope for rehabilitation of the cerebellum. And it makes it really, really challenging. As was seen in this case. Looks like there's a question.
Yeah, there are a couple in here. Would preservation of the tick at the time of the bite have helped with the diagnostic process?
I can address that. Minimally, if at all. I would say that, if it was preserved, we could identify it to be an ichthyoscapularis tick, which is the common vector for most cases of Powassan virus. But even if it were a different tick, that wouldn't exclude this virus. And most ticks that bite humans in New England are going to be ichthyoscapularis. So it might clue you in a little bit, but it wouldn't be too helpful. We can't test the tick directly for Powassan virus. There are, non-clinical testing-based labs that do that type of thing, but they're not associated with hospitals, and we don't offer that service.
We probably have time for one more question. There was one here on autopsy. Are there any clues as to the pathophysiology of the disease?
Okay. I'm not an anatomic pathologist, so I can't comment on that too much. I think that, findings in the cerebellum are very common, as well as the deep gray matter. The CDC can do immunohistochemistry for Powassan virus. So if you reach out to them, they can confirm the diagnosis at autopsy that way. But there's not a whole lot of these autopsies out there, very, very limited case series.
Dr. Harrold, I know you're working in this space. Anything you would want to add in terms of clues to pathophysiology?
I'm not sure that I have much to add to what Erik said. I mean, I think there's some tropism for the cerebellum, it seems like, but in the deep gray structures, but as to what exactly where that's coming from, I'm not sure.
Well, we're at time. Thanks everyone for joining us today. Look for this on the pages of the New England Journal in the coming months, and we'll see you back at our next CPC.
Thank you. Thanks, Meridale.
Thanks everyone. Have a great afternoon.
Thank you.